So I have no disclosures that are financial, but I am involved in several groups, either nationally or internationally, that focus on summarizing evidence related to this topic, which just means I'm very interested in this topic. Trying to go forward. Okay, the main information also in this seminar is available through this publication that's free. That was published in the last year, and it was a group of interested individuals. That's it, from pediatric intensive care, pediatric cardiac intensive care, cardiologists, neurologists, and interprofessional team members who came together to try to understand how to summarize the evidence for pediatric post-cardiac arrest care. And theoretically, if you click on this, it'll download the PDF for you. So the term that I will be using and will potentially be new to some of you is post-cardiac arrest syndrome. And it's been discussed in adults probably for over 10 years, but in pediatrics, it's only emerging. Not that the phenomenon didn't exist. It was really the fact that we didn't bring all the components together into a syndrome per se. And there's a general pathophysiology that occurs after cardiopulmonary arrest and resuscitation measures. We'll talk about some of the epidemiology, some of the monitoring and therapies, and I'll mention some of the tests that are used to make decision making when it comes to diagnosis and prognosis. And because this is a pediatric cardiology and cardiac intensive care course, there is an emerging literature, probably not very large yet, but if people have questions, and I'm happy to provide additional PDFs for anybody who can't obtain them. So what is post-cardiac arrest syndrome, and what does it mean to deliver post-cardiac arrest care? So as I said, the reference for pediatrics is from Top Gen and Al from 2019. And in adults, it was Bob Newmar, almost like I said, in 2008, who came together and coined that term. But the bottom line is that there is ischemia, and ischemia means that there is insufficient delivery of blood flow, which carries oxygen to organs. So ischemia, and then there's reperfusion injury that occurs after there is resumption or return of circulation. And I would say the cardiopulmonary bypass world has been instrumental in really developing the knowledge around that, which is how they've essentially developed and improved outcomes associated to this period of what we call flow, no flow, and reflow. In the context, unfortunately, of cardiac arrest, it isn't planned, and it isn't in the context usually where there's ongoing, I would say, monitoring and delivery of oxygen, which makes it more problematic for the organs. But this is the cartoon, and hopefully, I'm not sure if everybody sees my pointer, but if you go to the left part of the slide, the red color shows that there's normal flow of a certain level, and the y-axis is intended to be time, and the x-axis is time, and y-axis is the quantity of blood flow with oxygen being red. And it goes from normal to usually there's a circumstance that makes the blood flow being low, either low cardiac output, potentially sort of hypotension and shock, and then there's a period of no flow. And that's when the cardiopulmonary arrest is coined at time zero. And then there's some flow that's delivered during CPR, and conventional CPR provides about 20 to 25% of flow. And if there's oxygen delivered, then there's going to be some oxygen. And once flow is returned, either spontaneously or with ECMO or bypass, there's often a period of reperfusion and increase and supranormal flow that may or may not be actually either helpful or harmful to some of the organs. And then ultimately over time, flow stabilizes and returns to normal, but it probably takes about 5 to 7 days. Apologize for my roving. Whoops. So post-cardiac arrest syndrome, it can happen across the organs, and we're going to focus today on the neurological injury that can occur and on the myocardial dysfunction, mostly because, interestingly, the myocardial dysfunction occurs concurrently. The timing of one versus the other is not always uh, sequential or systematically in parallel, but myocardial dysfunction can continue or contribute to ongoing neurological injury. And the other organs are at risk. Also, we won't have time to speak to those, but if people have questions at the end, I'm happy to speak to them. And then there's often a precipitating pathophysiology, such as, for example, an ongoing, cardiac disease that may or may not need to be repaired. If we look at the phases, and why I want to talk to you about the phases, because you as a clinician, if you're admitting or caring for a patient after a post-cardiac arrest, the patient will be in post-cardiac arrest syndrome. And it's important for you to understand that there are the immediate phase, which is often 0 to 20 minutes, or in the first period, immediately after the event. Then there's the early phase, which is about 20 minutes to half a day, or the shift after. Then there's the intermediate phase, which will be the period of when there might be what we call increase in flow, potentially, and the clinical phenomenon is tachycardia and fever. And then the patient's organs will move to recovery, and hopefully, if the child survives, it'll be in the phase of rehabilitation. The time periods can vary between patients in terms of the duration of each period may vary between organs. And as I said, some patients will have if we had little brain probes in the brain, the heart, the kidneys, the lungs, and we measured flow, there may be these phases follow each other, but they may be of a little bit different duration in each. And some of you will have cared for patients where essentially there's return of circulation, the heart and the lungs are working, but the kidneys are actually in a phase of ischemia and not functioning. This will vary also based on chronological age, meaning a neonate, an infant, a child who's 7 years old, and an adolescent may not have the same duration of these phases, and how severe the ischemia was altogether. Essentially, how long was the cardiac arrest? If the setting was, for example, outside, if the child had or the adolescent had a VFib arrest, the impact will be different if there wasn't immediate resuscitation maneuvers, as opposed to a patient who's immediately post-op and all the measures were delivered immediately. And whether or not the patient is exposed to certain therapies, and the main one that can change the duration of these phases is temperature targeted management, which is intended to decrease metabolism. So how often does this happen? So from the data, and you might say, if you're caring for patients out of hospital, I would say post-cardiac arrest syndrome used to be quite rare because children didn't survive cardiac arrest. But I would say in 2020, and with recent data, even if the resuscitation successful survival of patients from out of hospital arrest is not very good, it still remains about 10% of events. And we believe that across Canada, and this is from a registry called CanRock, there's probably almost 200 children who have and suffer from post-cardiac arrest syndrome and will be in ICUs across the country. And in the US, it's more like almost 2,000 patients. For the in-hospital events, there's a lot more cardiac arrests that occur in children in hospitals compared to adults, for the ones of you who may be also adult clinicians. But there's almost 500 children in Canada annually who get cared for across pediatric or cardiac ICUs with post-cardiac arrest syndrome, meaning they've had a cardiac arrest and they survive and have a return of spontaneous circulation, and ultimately either the survival of these patients. And depending on the type of cardiac arrest, there's been a huge improvement in terms of the return of circulation. So it's depending on the type of arrest. It's either 40 to 15. It really depends on whether or not it's a full asystolic event. But the main key thing for you as a clinician is that because in hospital cardiac arrest is not associated with mortality, most of the time now you will have some of these patients under your care. So the overall estimates is that there's almost 6,500 children per year in the US and 650 in Canada. And the goal is for us is to improve the survival with favorable neurological outcome of these children. So the balance of the heart is and the brain is very important. Why is it important? And I'm going to give you data from different registries. This was an international registry that looked across 107 PICUs, 23 countries. And what they actually looked and evaluated that cardiac arrest was the second most frequent cause of acute neurological insults. And why is that so important is that it wasn't traumatic brain injury, seizures, or stroke, but the fact that cardiac arrest is such an important cause and that ultimately the mode of death is withdrawal of life support because of poor neurological status, it makes it really, really, really important for us to focus not just on cardiopulmonary resuscitation, but on cerebral cardiopulmonary resuscitation to really change the prognosis of these children. And this is a quality collaborative. Some of you may be familiar with PC4. Michael Alice Moga is our Sick Kids lead for this collaborative. And this is a collaborative of over, I believe now 50 to 60 units in the US and some Canadian units. Toronto was the pioneering unit with Steve Schwartz as the initial pioneer. And I believe now the group in Edmonton is looking to join, but it's a quality collaborative that shares data to improve outcome. And one of the things that they tried to evaluate was across cardiac intensive care units, what was the epidemiology of cardiopulmonary arrest. And what they reported in the paper led by Dr. Alton was that neonates were more at risk compared to infants, meaning if you were responsible for a newborn with cardiac disease, higher risk. If the cardiac arrests were more frequent within the 48 hours after an admission following cardiac surgery. If the child also had a genetic anomaly that came out in the analysis, if they had a smaller, lower weight, and if they had a previous cardiac arrest, they had been previously on ECMO, they had been readmitted, they had pulmonary hypertension, and they were listed for a heart transplant. The key other thing that they reported is still the overall survival of cardiac arrest and cardiac ICUs was above 53%, but it was probably closer to 37% if the patient had a single ventricle. But what is key is as a clinician, you know that if you're responsible for a neonate post-cardiac surgery within 24 hours and who's small, this patient, you'll have potentially greater awareness of their risk. And in terms of if they are as I said, previous cardiac arrest and previous ECMO, higher risk. And mostly because this group is trying to really prevent cardiopulmonary resuscitation events. I expect that in the next 1 to 2 years, there'll be upcoming data on the neurological outcomes of these patients. So what about post-cardiac arrest syndrome and brain injury in post-cardiac arrest care? So the pathophysiology comes from ATP energy failure, membrane failure when it comes to the synaptic transmission and even the astrocytes. Mitochondria become dysfunctional, and which makes the cells difficult to function. And then there's different pathways of cell death that neurons and different other neurological substrate cells end up starting their pathways to death. And then there's also oxidative stress and redox pathways. There's neurovascular unit is impaired and it makes for what we call the vasoreactivity difficult to be functional in the first, as I said, immediate early phases. There's cerebral edema that can develop in the first 72 hours, and then they'll ultimately be on imaging, what we call cortical and white matter injury. And ultimately, during the recovery phase, there may be ischemic neurodegeneration, which is what we're trying to avoid. Clinically, what you'll see is a patient in coma or stupor and agitation. And I'm sure some of you have taken care of adolescents or young children post-cardiac arrest who were actually just quite challenging to care for because they're agitated, they're delirious. Oh, I just heard somebody come on. I don't know if somebody has a question. No. And there can be seizures and myoclonus, which is one of the reasons why with the work with the neurology, acute care neurology service and Vanna Kazazian that we're deploying a lot more access to electroencephalography. There's cognitive and ultimately motor dysfunction. There may be persistent coma, dysomnia, and occasionally brain death. What happens to the myocardial? So the ischemia reperfusion injury will lead to a systemic inflammatory response and can also lead to altered vasoregulation, which means that there's going to be potentially some clinical shock. Your patient's going to be either vasoconstricted on clinical exam or vasodilated. Unclear why one versus the other. Interestingly, we can predict it in some pathophysiologies, but not in all. There will be an altered glucose metabolism and potentially hyperglycemia. We know there's also altered coagulation and maybe adrenal suppression. And there is data to suggest
Sorry, I'll just silence that. I had to step out.
And then there, in the focus on myocardial dysfunction, you'll have what you see at the bedside: hypotension, decreased cardiac output, decreased systolic function and ejection fraction as measured on echo, increased need for vasopressors, dysrhythmia, pulmonary edema, and decreased RV function. The myocardial dysfunction was described already several post-cardiac arrest almost 2 decades ago by Paul Checha. And what was key even early on is that ejection fraction was better, if you wish, or more preserved in patients who were likely to survive compared to patients who were non-survivors. And during the post-cardiac arrest care period, there is more recent data that within 24 hours of out-of-hospital cardiac arrest, a patient will have LV dysfunction and is associated potentially to worse outcome. So when it comes to monitoring and therapies for the brain and the heart, what are the options? You know about basics such as pulse oximetry, capnography, arterial blood pressure. And the reason why I still mention those is that there's actually emerging data for all these parameters. If they are what we call in extremes, will be associated to worse outcome. Therefore, it's really important to measure them. Blood glucose as a point of care, cardiac telemetry and echo, temperature, and we insist on continuous core, either esophageal, rectal, or bladder, whichever one you use in your organization. Urine output still remains a surrogate for kidney function. Blood gas measurements and lactates, electrolytes, chest x-ray, and central venous pressure. And when we talk about post-cardiac arrest syndrome specific to the brain monitoring, cerebral oximetry by regional saturation, the clinical neurological exam with serial measurements, EEG, neuroimaging both with computed tomography and magnetic resonance imaging. So when we focus on the brain after cardiopulmonary arrest, I really want to insist on what I call active supportive care and not passive supportive care, but mostly because it requires a clinician at the bedside who understands the importance of the details and of measurement and their importance of some of the what we call titration. And I would say in the cardiac ICU, that's part of what people are trained to do and selected to do. But it's just to give a sense of whether the patient has either cyanotic heart disease or a two ventricle physiology. The baseline oxygenation of this patient will be important to measure and maintain. Normalize CO2, maintain normothermia or hypothermia, depending on the local practice. But what is key is what we call temperature targeted management, hemodynamic stability with explicit set ordered targets, and seizure detection and control. So when it comes to what's the data on post-cardiac arrest care and oxygenation, it's become key and recommended to measure the PaO2 after return of circulation, to target a value appropriate to the specific patient condition, meaning that the patient who is at baseline has cyanotic heart disease, we would focus on their usual baseline. But what's key is that there's emerging data that normoxemia, meaning normal for this patient, is better with both survival and longer term outcome than hyperoxia. So in this, some of the emerging data came from a European database study where they had another quality type of registry, and they evaluated both in congenital heart disease, and I'll show you this slide, and non-heart disease patients. And normoxemia, meaning maintaining the PaO2 between 60 to 300 was associated to better survival versus hypoxemia, and that was in the patients without cyanotic heart disease versus hyperoxia. Mostly extremes are not good. And this was in congenital heart disease. And so you see on the left, on the y-axis, you have the probability of death. So the probability of death was at its lowest in the 1 month, the 1 year, the 3 year, and the 5-year-old, closest to about 60. And in patients with no congenital heart disease, they represented and they replicated a similar graph. But the main thing is that extremes, essentially 600, or inadvertent delivery of very high levels of oxygen, is actually not good. The same thing, and this is a different group, evaluated what we call extremes of CO2 or capnia after return of spontaneous circulation. And again, they show that targeting a value appropriate to the baselines of the patient's condition was best, meaning hypercapnia, PaCO2 that's too high, above 50, or too low, below 30, was independently both associated with death. When it comes to temperature and the impact on the brain, we have now what we call the THAPCA study results. THAPCA was a multi-center hypothermia therapy versus normothermia therapy trial in both out of hospital and in hospital arrest. And what the THAPCA trial actually showed, and we were one of the sites, is that in comatose children who survived out of hospital cardiac arrest, and the same conclusion was true for in hospital survival, there was no benefit to hypothermia versus normothermia at 1 year. And they maintained these tight temperature for 48 hours. However, what they did show is that the outcomes in this trial, though, were better than in previous studies where there had been fever. And I'm just giving you a sense of, so in the first 6 hours, though, that we didn't have information, and there was either induction of hypothermia or normothermia for 48 hours and then rewarmed and then followed through. The same thing, as I said, the in-hospital cohort, they didn't have a benefit. The main thing is that both actually, like I said, potentially involve mitigating and avoiding fever, which is our current practice. Right now here at Sick Kids, we'll try to aim for normothermia. The practice that we didn't change is for the ECPR subgroup. We currently still start at 34 degrees, and then we'll either maintain that for 24 hours or go to normothermia with proper understanding of the impact on the hemodynamics. But we will not tolerate fever. And this is when we talk about, and we've moved to being quite fortunate in having electrophysiology and neurologists with acute care neurology service supporting patients. So the standard has become that post-cardiac arrest, given the fact that in patients, again, who are comatose after an event or cannot be assessed because they have to maintain sedation and paralysis, the standard would be to detect electrical evidence of cortical function or dysfunction and to diagnose seizures with EEG and the full montage EEG. Why we have some early evidence, and the group that's pioneered these results is the group out of CHOP, and some others are replicating similar results. And both, if you measure electroencephalography within 12 hours, actually, you can detect whether or not there's a normal, a slow or disorganized or discontinuous or attenuated and flat background. And if you look at, and this is, I put what we call, if you look at the probability of unfavorable outcome, you can actually evaluate the difference probability, whether or not the patient, for the same what we call clinical characteristics of arrest location, initial cardiac rhythm, the number of epinephrine doses, and the witness status of the event. If there is EEG information, we're not as able to detect the probability of unfavorable outcome, but the EEG in this cohort allowed for additional ability to predict unfavorable outcome. We use, and I'm just going to pause, we use EEG in our environment not just to try to predict outcome. I would say that at Sick Kids, we really use it to detect seizures and to treat seizures. There is, and Dr. Hahn and colleagues have shown in not just in cardiac patients, but in general, I would say ICU patients, the burden of seizure, meaning the quantity of seizure as a whole in after acquired brain injury, such as cardiac arrest, would be important to understand, because more seizures essentially is associated to worse outcome. And you might say, gee, well, Emery, that makes sense. Well, it actually, for many, many years, it wasn't clear without the data that was generated that seizures per se were not just an evidence of injury, but that they could also contribute to ongoing injury. So neuroimaging, I would say in our organization also, and the current recommendations are to use it to diagnose the etiology of potentially an event or an arrest, and that there's probably not enough information yet to understand whether or not it can serve to really do a prognosis. But we use it, and we recommend using it really to understand if there are treatable causes. So cerebral edema is actually visible on CT and eventually on MRI. And we know that the cortex is more vulnerable than the brainstem, and that the basal ganglia is more vulnerable than the cortex. So with the help of our neuroradiologists, we evaluate different parts of the brain on imaging to understand which ones may have ongoing injury. And in most importantly, in patients who are on ECMO, we'll look for cerebral hemorrhage. These are CTs on day 2 in patients, and you can see these are axial views. And usually the top of the picture is where the nose would be, and the back is the back of the head. And the inside part of the brain should all be more what we call gray with some gyration. And you can see that the black areas on the left side of the day 2 shows severe cerebral ischemia, which are not as visible on the other side. So people are trying to evaluate the value of CT images after an arrest, and depending on the type of arrest, for example, we usually assume that there is more profound ischemia in out of hospital events. And there are some American groups like Dr. Tufshen's group that have shown that even within 3 hours, if there is a loss of what we call gray-white differentiation on CT, that can indicate poor outcome, and that a normal CT will actually be more likely to be associated with a favorable outcome. So when it comes to supporting the heart to maintain, I would say, the best neurological outcomes, again, active monitoring and therapies for the myocardium. And luckily, the therapies for the myocardium and the post-cardiac arrest care syndrome decrease RV and LV function are aligned with the brain's also supportive care. The key things to note, and we don't have time to speak about these a lot today, is that there's still cardiopulmonary interactions related to mechanical ventilation to try to optimize oxygenation and CO2 that need to be carefully adjusted to make sure that we support the heart properly after such an event, and we also don't impair the cerebral vascular physiology. And the main aspect of that is, I'll just mention, is PEEP. PEEP may be helpful for the left heart and may be helpful for pulmonary edema, but high PEEPs will decrease the brain's venous return and can compromise in the cases of cerebral edema. And intravenous fluids and inotropes are often helpful.
The sound seems to be buffering at the moment. Anne-Marie, are you still there?
What else do we know? Hypotension occurs.
Anne-Marie?
Yeah.
Is it possible just to back up a couple of sentences? It felt like there was no sound.
Yeah, you know what? I saw a little message on my computer that said my connection was unstable.
Okay.
Is this the slide okay?
Yeah.
Okay, so when it comes to active monitoring and therapies of the myocardium, I'm going to say that usually overall supportive cardiac care is aligned with neurological care, especially for hemodynamic optimization of the right ventricular failure or left ventricular failure. Cardiopulmonary interactions when it comes to mechanical ventilation have to be carefully considered. And the main element that I mentioned before that may have been bleeped out is PEEP. PEEP, when it is increased at high levels, probably around above 7, can impair venous return from the brain. So while it may be helpful for the heart after an event to optimize LV function and decrease pulmonary edema, one has to be very careful with its impact on the brain because of the modification of the venous return, and essentially it decreases cerebral perfusion pressure. And intravenous fluids and inotropes are helpful for the myocardial support, but have to be used carefully because, and the example I use is epinephrine. High doses of epinephrine are occasionally used after cardiopulmonary arrest, but we have data to show that the epinephrine crosses the blood-brain barrier and may affect and worsen cerebral ischemia if it's not titrated carefully, which is why in some groups, people are considering, and you may have heard that we should potentially, once we're considering mechanical support, we should minimize the use of epinephrine, and potentially using mechanical support such as ECMO and VAD in some patients may be preferable than very high doses of inotropes for a long time. The key conundrum, though, is that, after cardiac arrest, we do see hypotension, and there was a secondary analysis of the whole FABCA trial that even looked at across the over 300 patients, how many patients were hypotensive and what happened in the ones that were hypotensive. And this is a slide that summarizes that within 6 hours of, I would say, if they were admitted for cardiac arrest, within 6 hours of admission, there was almost a quarter of the patients who were hypotensive, and hypotensive per se was associated, there was early hypotension, there was late hypotension, but early hypotension was associated with lower survival, which makes it paramount to be so focused on that parameter post. But I just told you in the previous slide that you may not want to use too much epinephrine. So the main thing is careful use of fluids, vasoactives, and inotropes. We actually don't know which combination of these interventions is the best, and there's probably going to be some data available in the next 5 years. But in another registry trial, the same evidence, 50% of children in the first 6 hours after, the PCARN registry is an even larger registry. It's a pediatric emergency and critical care American registry. And there's, I think, over 50 units. And early hypotension was also associated with in-hospital mortality and worse neurological outcome. So when it comes to post-cardiac arrest care and prognostication, I think the main thing I'm going to say is that there's pre-arrest factors that your patients come with that may affect their prognosis. And then there's arrest factors. And I gave you early on in the cardiac ICU population, there was the fact that, they were single ventricles, had potentially worse prognosis than two ventricle physiology. But these are arrest factors when it comes to resuscitation. But ultimately, there's what we call things that are associated or factors associated with good outcome and bad outcome. And I'm going to summarize that a shorter duration of an arrest is associated to a better outcome. A witnessed event is associated to a favorable outcome compared to, I call it an unwitnessed ward event or unwitnessed out of hospital event. A conventional CPR that's short is better than prolonged CPR. Good quality CPR is better than bad quality. eCPR if it's used early versus late. If there's oxygenation and carbon dioxide measurement, best to focus on normal values for the patient. Blood pressure should be normal, or even some people are suggesting high, but the current data is focusing on normal tension. In TTM, meaning measured temperature, it's either normothermia or hypothermia, but should avoid fever. Imaging is helpful if it's normal and or globally very abnormal, but it may be helpful to diagnose an etiology, and EEG is helpful to diagnose seizures and treat them. I would say if people are asking if there's one single best test, I'm going to tell you there's no single one test that is helpful for prognostication. And some people have come up with also a separate statement. There's, I think, 2 paragraphs for the pediatrics, but it's still a valuable American Heart Association that essentially sort of makes people concerned about early prognostication, and probably waiting at least 96 hours is currently recommended because of the impact of certain of the interventions potentially on improving neurological outcome. Early optimization, I come back to focusing on oxygenation, ventilation, blood pressure, and circulatory support, treating or understanding the precipitating disease, temperature, sedation, neuromuscular blockade potentially, and seizure detection and treatment. And I believe you're going to have a lecture on that today. And if not, I know it's planned in your curriculum. And focusing on glucose and other metabolic anomalies that can be easily modified and treated. We should avoid what I call passive care, mostly because we know that we can make a difference now. 10 years ago, there was a lot less active care because people thought that the prognosis was so grim. I think so it's active care versus passive care, and we should avoid hyperoxia or hypoxemia over enthusiastic, I would say hyperventilation or hypocapnia. We should avoid hypotension, avoid hyperthermia or fever. And we would probably discourage blind therapy of hypotension, which means measuring intraarterial blood pressure, and blind therapy of seizure also, because the recommendation is to use continuous EEG. What we don't know is, to be fair, we don't know how long the brain really needs to recover. Ultimately, with these targeted therapies, is it 5 days? Is it 7 days? How long should we maintain the patient in coma? How long should we maintain the targeted temperature? Does transfusion therapy make a difference? And does antimicrobial therapy make a difference? Interestingly, there's a group in France who's asked the question in a large cardiac center for adults. They've actually just looked at whether or not it makes a difference to give antimicrobial therapy or not, because potentially it may be there may be a signal that allows us to understand that treating blindly may be helpful. I believe the current adult data shows a decrease in pneumonia, but not a change in overall outcome, and whether or not nutrition or how nutrition needs to be delivered. And I expect that with Dr. Flo and Dr. Matawe and Joanne Harridge and Lori Tura, in the next, I would say, 5 years, we're going to have a lot more information on how best to either deliver glucose or potentially induce ketosis after cardiopulmonary arrest during post-cardiac arrest syndrome. Rehabilitation and recovery is emerging to being very important. We just don't know how much and when, in terms of type and timing, and is there an opportunity to also start certain medications early, and are there devices that may be helpful? Ultimately, I would say that promptly after return of circulation, there should be a focus on focused active care, a systemic approach, and focus on the heart and brain, or brain and heart, whichever one you prefer, but both will be helpful. Thank you. Cecilia?
Yes.
I'm looking at the chat. There's no question.
No. Does anyone want to put their mic on and ask some questions for Anne-Marie? We have comments of great. All right, thank you, Anne-Marie, for reviewing the mechanisms of cerebral injury and cardiac disease and cardiac arrest, and teaching us about the active monitoring and cardiac arrest supportive care, and showing us lots of best evidence behind the intervention, as well as the prognostic factors. That was an excellent presentation. Thank you. Oh, we do have a question, it looks like. What type of EEG?
We currently, in terms of portable small ones, currently right now, because the parts of the brain that have a likelihood of seizing are cortical and can be also in the occipital area, our standard is not to only use 2 to 3 EEGs on the prefrontal area, because those areas may not be sufficient to detect seizures. I believe that currently our approach is only to use these, I would say, limited amount of EEGs in the context where we can't have the resources. There are some emerging technologies with, I like what you call easier ones to apply, but because it's global ischemia, and especially in the younger infant, the global ischemia can be in the posterior circulation areas. it's difficult for us to recommend only partial EG on the prefrontal area.
Thank you. Any other questions? All right. Thank you so much, Emery.
Thank you for the opportunity, as always. Thank you, Cecilia, for such a great day. Thank you.
Thank you. Bye. So everyone, our next speaker is at 1:45. So we have about an hour. All right. See you soon. Any questions for me?